I'd like to thank the organizers for inviting me to speak to you today about Imdusiran combinations, achieving surface antigen loss. So I will get right into it. My disclosures. So why is surface antigen loss important? I think the benefit of coming late in this day is a lot of people have already mentioned some of these topics, so I'll be brief here, but we know, or we hypothesize, that circulating surface antigen contributes to immune exhaustion in chronic hepatitis B patients, and there's a very nice schematic up at the top here that will show you some of the different pathways where this may impact. Surface antigen seroclearance may decrease the risk of future HCC, cirrhosis, and fibrosis progression, and there is some clinical data available out there. I would point you to this very nice paper from 2018 showing that if you induce seroclearance, you can actually reduce your risk of future HCC development, so this could have clinical implications as well. And as has been mentioned previously, low surface antigen levels may be predictors for achieving functional cure in the clinical setting in regards to discontinuing nuke therapy in clinical practice, especially with surface antigen levels less than 1,000 or less than 100, depending on the population. And also, as we've heard throughout the day, recent clinical trials showing higher rates of surface antigen loss in subjects with lower baseline surface antigen levels, for example, less than 3,000 or less than 1,000. So we at Arbutus, as many of our collaborators know, have had a longstanding belief that we need a three-pronged approach to therapeutic success, and this has been mentioned again by several other speakers regarding suppression of viral DNA, suppression, I don't have my pointer anymore, of viral antigens, specifically surface antigen, and then a key component we believe of this is targeting the host immune system to try to boost responses in these subjects that are in our clinical trials. And has been mentioned as well, RNAis can do this across all different pillars, and then we have several options for manipulating the host immune system. So Imdusiran, or formerly AB729, is our lead therapeutic at Arbutus. It is a single-trigger siRNA that targets all HBV transcripts, including the HBx protein. It has pangenotypic activity, in both in vitro experiments and in the clinic to date, complementary with other agents, and I'll show you some of the clinical trials we've performed to date, and a favorable safety profile both preclinically in terms of our long-term toxicology studies and in our clinical studies to date. So this is an overview of the trials that we have had either completed or ongoing with Imdusiran. So we had a quite expansive phase 1A, 1B clinical trial that I'll touch on briefly, and then several combination clinical trials with various other mechanisms, including a capsid inhibitor, two immunomodulators, which are the two studies I'll focus on. And then we also have a long-term follow-up study for subjects who have achieved nuke discontinuation in our studies to monitor long-term outcomes, as well as an ongoing liver biopsy study in collaboration with the University of Maryland. So in this particular schematic, the trials that have a star are the ones where we've achieved surface antigen loss, so I'll touch on those. So our first clinical trial was our 001 trial. This was a phase 1A, 1B clinical trial. We've presented data on this trial for several years now at various conferences, but just to remind you, in this trial, we did look at single doses of Imdusiran in both healthy subjects and subjects with chronic hepatitis B, both virally suppressed and treatment naive, and showed robust surface antigen declines across all of these patient cohorts, as well as reduction of HBV DNA in the DNA positive cohort. In part 3 of the study, we tested a variety of treatment doses, treatment durations, treatment intervals in different populations. So looking at every 4-week dosing, 8-week dosing, every 12-week dosing, 2 different dose levels, and then both DNA positive, nuke suppressed subjects, and e antigen positive subjects. And what I'll show you is just a snapshot of the data from this trial. Again, we've presented this data at various conferences throughout the years. But the key I would highlight here is we have been able to show surface antigen loss, but in a very limited number of patients. And these are patients who were treated with a nuke and with Imdusiran for a 48-week treatment period. Again, dose may be different, interval may be different, but you can see, we do get a patient here with S loss that was maintained with actual antibody production as well. And then a few patients down here where we were able to achieve surface antigen loss either intermittently or sustained, but small numbers. So really contributing to the hypothesis that we need to add something else to a siRNA and a nuke therapy to really boost the numbers that respond. So that brings us to our ongoing phase 2A clinical trials. So these trials, we looked at the addition of some kind of immunomodulatory component to imdusiran and nuke therapy. So this is our IMPROVE-1 clinical trial. In this trial, we looked at interferon as a representative immunomodulator, and we enrolled subjects who were nuke suppressed, e antigen negative, and all of them received a lead-in period with imdusiran, so up here at the top box. The goal here was to reduce surface antigen as much as possible before the introduction of the immunomodulator, in this case, interferon. So in this particular trial, we randomized subjects for short courses of interferon, so either, I lost my cursor again. Here we go, 24 weeks of interferon here at the top. Within this 24-week group, subjects could either continue their imdusiran dosing, so get 2 more doses, or they received just interferon with no additional imdusiran. In the bottom here, we had subjects receive 12 weeks of interferon, either again with ongoing imdusiran dosing, so 1 more dose, or just the interferon dosing period. All of these subjects then entered a 24-week nuke-only consolidation period, and at that point, they were eligible to discontinue all therapies, so discontinue their nuke therapy if they met protocol criteria. And we did present some of this data earlier this year at EASL. We do have a late breaker poster here at AASLD with additional follow-up data. But I will cut right to the data presentation here. So I will draw your attention to the 2 24-week interferon cohorts, so cohorts A1 and A2. They performed better than the 12-week cohort, suggesting that 12 weeks of interferon is not enough to generate high levels of surface antigen loss. But in the 24-week cohorts, the time points are here on the left-hand side of the table. So subjects who achieved surface antigen loss at any time during treatment, at the end of treatment, so when they completed the interferon dosing period, 24 weeks post end of treatment, so at the end of that nuke consolidation period, and then functional cure when they have stopped all therapy, and then 24 weeks have passed with sustained S loss. And the functional cure data will be presented at the upcoming meeting. But you can see from what we presented at EASL, in the group that received additional imdusiran and interferon, we had half of the subjects achieve S loss at any time during treatment. If we further look at the group with baseline surface antigen less than 1,000, we see that we were able to increase that response rate to 67%. At the end of treatment, the number with S loss dropped a little bit, 33% with S loss, but the same percentage with low surface antigen at baseline. And then we maintained that S antigen loss throughout that nuke consolidation period in all of these subjects. In the A2 cohort that just received the 4 doses of imdusiran plus 24 weeks interferon, so no additional doses, we did also achieve a good number of subjects with S antigen loss, 23% at end of treatment. This dropped to 15% at the end of that nuke consolidation period. But again, in the low S patients of less than 1,000 at baseline, we had approximately 30% that had S loss that was maintained for that 24-week nuke consolidation period. The interferon treatment duration in this particular study was quite well tolerated. So the 24 and 12-week courses, we had no serious adverse events. We had no AEs leading to discontinuation in these subjects. So in general, I think a better tolerated regimen than the 48-week regimen in some of the other studies that have been conducted. So the other study I'll highlight is also a study with a similar design, looking at imdusiran with the addition of parentheses VTP-300, which was described earlier in the session. So in this study, similar design, we took nuke-suppressed subjects, treated them with 4 doses of imdusiran to drive down surface antigen, ideally to that level less than 200 IUs per ml. And in fact, most of the subjects dropped down to less than 100 IUs per ml at the time of randomization to either active VTP-300 or placebo. These subjects, again, at week 48 were assessed for their ability to discontinue all therapy. We presented this data up top at EASL earlier this year, and I'll show you that. At AASLD, we actually will have preliminary data on this additional cohort here, Group C, which adds the low-dose nivolumab component to the VTP-300 regimen, which was described earlier. So this is a late-breaker presentation coming up at EASL. So just data presented again earlier at EASL. So you can see, I think this has been showed a couple times now, but essentially Similar drops in surface antigen with the active treated group, VTP-300 group, and the placebo group through approximately week about 60 here, and then you start to see this divergence in surface antigen responses, with the active group having lower surface antigen at this week 72 time point versus the placebo, which is starting to rebound. And we did achieve some surface antigen loss in this study as well. We had one patient here in the active group achieve surface antigen loss at week 72, and a couple other subjects that are very close, either less than 10 IUs per ml or less than 100. And we did have a subject in the placebo group also who's an E-positive subject that did achieve S loss at week 48. So again, additional data from this will be presented at AASLD this week. So in conclusion, it is possible to achieve surface antigen loss with just siRNA monotherapy, but very low rates, unclear significance and durability. And so really an addition of an immunomodulator may be quite necessary. The design of these studies may be important, meaning that deep suppression of surface antigen prior to adding the immunomodulator may be important to maximize efficacy. And so far, short courses of interferon appear to have the best balance of efficacy and safety in this population. And we are obviously exploring other classes of immunomodulators, such as checkpoint inhibitors and the VTP-300 therapeutic. And then our additional presentations at AASLD are highlighted at the bottom of the slide, including some immunologic data from the IMPROVE-1 study. So with that, I'd like to thank all of our patients, study subjects,